here. Let's take a look. How do we sound? Hmm? 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 Mm-hmm. Okay. I think it sounds okay. I think it's okay. Okay. Well, everything sounds like it's up and running. So what we will do is we will just share this real quick. And once we share it, we will get going. Okay. Okay. Almost there. Almost there. Almost there. Just a sec. So sorry. Okay. Alrighty. Well, I think that is it, and we are ready to get going. Good afternoon, good evening, good morning, whoever you are, wherever you are. I am indeed Dr. Patrick Lockwood, and for the purpose of this podcast, I'm just Patrick, and this is UnShrink Me. So welcome to yet another episode of UnShrink Me. If you are brand new to the podcast, this is a weekly podcast on Saturdays that is focused on the consumers of mental health services. So this podcast is specifically dedicated to the people trying to get better and all the challenges they're having. And so if you're brand new, just know that every week I go to Twitter and I go to the various posts I bookmarked over the past few weeks or months, and I come back to topics that I think are relevant for what's happening in the ether, and make sure that, every post is given full criticism and fair criticism, because this is a podcast for the consumers of mental health services. I want to make sure that whatever you're reading and hearing and listening to, including this podcast, is as well critiqued as humanly possible. And so all I'm trying to do is make sure that if you're out there and you're seeking help, that you're getting as much help as possible from the services you're seeking, and that you're not being misled by us, the profession. So this is me critiquing the profession mostly. And as always, if you are new to the podcast, this is the Psychology Checkup. That's my YouTube channel. And the podcast is called UnShrink Me. And if you want to follow me on Twitter so you can read along the tweets that I'm reposting, my handle is at AlobhaPatrick, at ALOBHAPATRICK. And without further delay, we have so much to talk about today. We're going to talk about psychiatry. We're going to talk about personality disorders. We're going to talk about mental health in society. And I think the most important topic probably for today is it's a question of, what exactly is it that we have in our wheelhouse that's in our control here, and what really can we do to make things better, I guess, is a question that everyone should be thinking about, because improving the image of psychotherapy is something that's trendy, and a lot of people in my community talk about it, so I want to talk about that a lot today too. Hello, Jonathan. My buddy Jonathan's here. Glad to see you, dude. And as always, if you're brand new to the UnShrink Me universe, this podcast is not NOT, sponsored by Celsius. However, I love this stuff, and it's on deck. So, without further delay, we're going to get going. If you're brand new, just know that I always start with the softball post, something light and simple to get us into the spirit of things here. And so, one of the topics I tweeted about today is it a personality disorder or is it not? So let me just retweet this right now, and then we can get into it. Okay. Just 1 second. So sorry. Be right with you. Okay. So, some person that I've never heard of or interacted with posted this screenshot of someone talking about being diagnosed with a personality disorder. Apparently, some psychiatric nurse diagnosed somebody with a personality disorder when they're having the symptoms of low mood and all this stuff. And the person said it must be a personality disorder then if you are having side effects, such as an mental health nurse practitioner. And the comments under this post were really vicious because I think people are tired of being pathologized and being diagnosed with a personality disorder. And so let's be clear that if you're taking a bunch of psych meds for your mood dysregulation and they're not working, and the person you're talking to, the psychiatrist, the psychiatric nurse, the psychologist like myself, whatever it is, they jump to, well, if none of these meds are working and your mood's still a giant mess, you must have a personality disorder. If that is their logical thought process, I said, this is a tweet that I wrote in rebuttal to that. Well, there are multiple alternatives. Though a personality disorder can be the reason meds do not work, it might not also be depression, for instance. You might have the wrong diagnosis because I think in this example, the person was diagnosed with depression, but none of the words are working. Another example is it could just be another disorder. For instance, other disorders have low mood symptoms, but will not respond very well to meds. For instance, head injuries, hormone issues, things like that. Also, another hot tip, quick fact, sometimes prescribers are absolute idiots. They don't know what they're looking at. They ask you vague questions about symptoms, excuse Godzilla here, and these vague questions about symptoms don't actually get at what's really happening. So you can self-report low mood, but they don't ask you enough questions about other types of symptoms or causes, and so they jump to depression because it's an easy stereotype. I said also the patient could have a metabolic disease. They could have a diabetes problem or something like that that causes their mood to swing radically based upon insulin and things like that. So it's really important. Willow's going to be in the shot here. Sorry about that. But she wants some attention. So, but like, there's dozens of reasons literally why you can have a persistent low mood that doesn't respond to medications. Head injuries, illnesses, infections, metabolic diseases, all sorts of things. And furthermore, if you're just having a reaction to life stressors, it certainly could be the case. Certainly could be the case that your low mood is just a reaction to the insanity of your life. Looks like Ryan's here. He says, hey, headed out to do suburban dad stuff, but have fun. Good to see you, sir. Glad you dropped by. So first and foremost, sometimes you do have a personality disorder and you don't know it. That's possible because personality disorders are egocentric, which means that you see through the filters and lenses of your personality differences and life makes sense to you. So most personality disorders are egocentric, which means you wouldn't really know that you have them. You wouldn't pay close attention in a way that would allow you to see that, the world is shaped differently than you think it is. So sometimes it is a personality disorder. Sometimes your prescriber is just an idiot, and I would go there first probably more than I would go to, it's a personality disorder. But it could be. It's a somewhat common experience. So that's our kind of quick softball starter for the day. I want to talk a little bit right now about my buddy Ed Perrin. So some of you know Dr. Perrin on Twitter, and some of you do not, and that's okay. There goes Willow again. Look at that girl. Anyways, so my buddy Ed, our buddy Ed, I think said something really important, and I want to talk about it because I think it's important for everybody. Darren, good to see you. Glad you're here, sir. So let me just retweet this. Okay. Okie dokie, just a sec. Almost posted, and there we go. So about 6 days ago, our buddy Ed, Inspired by Reason's here. Glad you're here. Let's get some drama going. Inspired by Reason, let's do it. You said you're here for the drama. Let's create some drama. So, and maybe we can do that with this post. So 6 days ago, Ed Perrin, psychologist, one of our buddies, I think, said the following 6 days ago. And if you don't follow him on Twitter, his name is at DOCTORPERIN, at Dr. Perrin. Here's what he said. What can be done to restore public trust in psychotherapy? Very simple question. I think it's a great question, and he got great responses from dozens of people. So here's what Dr. Perrin said. He said, and I quote, "What can be done to restore public trust in psychotherapy?" So here's what I said 6 days ago in response to that. I said, excellent question. In one sense, We could show more examples of competent clinicians publicly. We could encourage patients to speak up about what actually worked for them. On the other hand, nothing, as in nothing, can be done to restore the public's trust in psychotherapy. Because therapy isn't the problem. The problem is shitty culture, families that suck at being families, economic turmoil, lack of values, corrupt government, and a media tech ecosystem designed to keep us sick. No amount of therapy can change a screwed up culture. So that post that I made in response to Dr. Perrin's tweet is, I think, a confusing post, because on the one hand, it's somewhat optimistic. On the other hand, it sounds kind of pessimistic. So let me walk this out for everyone. I think there's definitely a world in which more competent people who do good work in psychotherapy can show up online, start podcasts, Substacks like some of you here do. For instance, for those of you who are here watching and listening, a couple of people in the chat have their own podcasts, like Ryan and Darren McGee, and they have Substacks like Jonathan. And so it's really important to be on top of these mental health providers and see what they're saying, because these are people that, if you were to ask them, they think they're doing pretty good work, right? And so you can go see what they're putting out publicly and see if it's actually, aligning with what you think would be helpful as maybe a patient yourself. So I think more competent clinicians online talking about what they see as helpful, generally. And there's lots of people like Dr. Perrin and Grant Brenner and a few of the other psychoanalytic types that do this. I think Jonathan Shedler does this. I think a lot of people do this. And then on the other hand, I also think there's almost nothing that professionals can do to restore our trust in psychotherapy. Club Exile Jeff, he says, we should start a network. What kind of network should we start, Jeff? What do you think? What should we do? Give us solutions. So I said there's really nothing that mental health professionals can do to restore the public's trust in them. And the reason that I believe this very firmly is I genuinely believe that psychotherapy, when it's done well, is doing its job well, and no one ever hears about it. And I genuinely believe, without any cynicism or negativity, that competent clinicians are just quietly typically doing a bunch of good work and no one ever hears from them or their patients, which is great. And I'm so happy that there are so many mental health professionals of all backgrounds and degrees and cultures and all this stuff that are just out there doing their job. And you would never know that they've touched dozens, if not hundreds of people's lives. That's out there. That's happening right now. As we speak, there are dozens and dozens and dozens of really competent clinicians who have a master's degree or a doctorate degree, or they're psychiatrists or whatever. And they're out there and they're doing really solid therapy, and they're helping people, and they're doing lifestyle change and cognitive change, and they're seeing themselves differently, and the patient's operating differently in the world, and life is generally getting better, albeit not perfect, right? And that's success in therapy for most people. And that's happening every day. And we just never hear about it. We never hear about all the good things that clinicians do, because those people are just doing their job, and they don't have a specific need to advertise that their work is helping people. And so I want you to understand, if you're a consumer of therapy out there, if your family member's in treatment or something like that, there's a really, really good chance that competent people, you've never heard of them. They're not famous. They're not popular. They're not Dr. Matcha Latte or Jordan Peterson or whatever. Like, the vast majority of super competent people that help people, you will have never heard their name, and they're just out there doing good work. And the real problem is people are trying to apply therapy to life problems that therapy cannot fix. If you are hundreds of thousands of dollars in debt, there is no amount of acceptance and commitment therapy that is going to change the fact that your life is unfairly burdened by that debt, right? Like, that's just a fact. You are in insane amounts of debt, and it is going to be a consequence for you in some way, shape, or form. You said you want to start drama inspired by reason, so that's my attempt at making fun of Gabor Mate. And so it's really important, I think, to be 100% clear that the vast majority of people when they have psychosocial suffering that's not actual mental health problems, there's no amount of therapy that's going to magically make their life better or even progressively make their life better. Because if they're still making bad choices with food and exercise and sleep and relationships, and the therapy is not designed or focused on that, then there's nothing therapy is going to do for that. You know, so I gave the debt example, but there are dozens of examples of how therapy is not the solution at all in any way, shape, or form. And so I think one of the problems we have is people are trying to apply therapy to things that it doesn't apply to. And a lot of people are not trained to deal with other issues very well. So I think that's half the problem, at least. And I don't think there's anything psychotherapy can do other than, let's get out of the business of trying to help people with things we're not supposed to help them with. Business, for instance. Club Exile says, we should start a network of podcasters, YouTubers, bloggers modeling good mental health care and ecosystem. Yeah, I'm interested in that. I just don't have the energy or effort to create it myself. But if y'all want to get together, sign me up, So for me, I think there's not much we can do to restore the public trust in psychotherapy, because I think the problem is that many of life's issues are not helped by therapy. I think that's completely not the point, right? So for me, there's not much we can do. I think what we can do is we can certainly continue to highlight examples of people we think are doing good work. What I try to do with my colleagues, with my friends, with my supervisees and interns and things like that is showcase good examples and talk about people I think are successful. But I don't believe that there's anything that we need to do from a PR perspective to radically improve how therapy is perceived in the universe, in my opinion at least. But I'm open to other thoughts, obviously. So thank you, Ed, for that grist for the mill. I appreciate you. And so I want to talk about psychiatry. And I don't normally spend a lot of time talking about prescribers of medications because I am not a psychiatrist, and so I can speak, from the perspective of someone who teaches psychopharmacology, because I do that. I can speak from the perspective of someone who's worked as a psychologist with people who are having adverse effects from medications, but I cannot speak from the perspective of what it's like to be trained as a psychiatrist. So this next comment or series of comments is not because I equate myself to being a psychiatrist, just so we're all clear. So we'll see how this goes. Feel free to sue me, cancel me, so on and so forth. So my buddy Nick Tabor, as always, says lots of provocative, fun things. And so let me retweet one of his posts. Okay. So Darren McGee says, I guess it's about managing expectations about what therapy is and what it isn't. Absolutely. And I think we can do that on an individual basis, but publicly, I don't think any organization can do that effectively because it's too complicated. At least I generally agree with you, but only on an individual basis. So Nick Tabor, and if you've never interacted with him on Twitter, etc., his handle is at NickTaber. Nick Tabor retweeted something from Chris Palmer, who is a psychiatrist who focuses on metabolic approaches to psychiatry. And Dr. Palmer said, psychiatry has helped millions of people, basically. Edmund in the chat here says, do psychiatrists test the drugs in themselves? Not usually, I would imagine. It's probably not a good idea anyways. But back in the day, Freud did a lot of cocaine with his friends. So, for what it's worth. So anyways, so Nick started his post 4 days ago with psychiatry has helped millions of people. And then he said, we really don't know how many people psychiatry has helped. Psychiatrists can just define what they've done as having helped someone without that actually being tethered to reality. They can redefine harm as help, and the same is true of clinical psychology. And as always, when Nick posts something like this, which is rather incendiary, I try to be reasonable about it and see if there's some good and some bad in there. So The quote is, "Psychiatry has helped millions of people," from Dr. Palmer. And I think if we look at the history of psychiatry going all the way back to the 1800s, when it was more formally established, I would say that yes, it is very likely that psychiatry has helped millions of people. Now, the real question that everyone listening and watching should be thinking about is, what does it mean to medically or professionally help someone, right? And so I'm not trying to play a word game here or anything like that. I think it's a valid practical question. And this is the concept of informed consent over and over and over again. If you are fully informed of the potential pros and cons of a strategy to manage your suffering, and you're aware of the potential cons, then, if you achieve the goal you would like to achieve, even with consequences, then it's helped you in a way, right? I think that's my practical common sense definition. Now, once you start digging into the randomized controlled trials about these various medications and what they've done to people to both help and harm them, I think the picture gets rather muddy and blurry very quickly. So Nick said, we really don't know how many people psychiatry has helped. And I disagree with that. I think we actually have some interesting estimates. And I think you can go by some practical definitions and then some non-practical definitions. So practical definition 1, did we keep people alive? As silly as that sounds, sometimes people are at risk of dying right now, right? They're at risk of self-harm. They have command hallucinations that say, kill yourself. And so if that person is given a medication of some kind, either against their will or with their permission, to keep them alive and they do not die, to me, that is a major win. It might be traumatizing for that person, and it's still a win because they didn't die. And forgive me for being a practical person, but I like people not dying, So that's helping someone, in my opinion. A second practical definition of helping someone is, were they able to function better in their life per their own self-report, right? And so from that score, I'm sure millions of people were able to function better because of their medication. And I can count probably dozens of examples on, in my career where people were helped by various medications, whether it's antidepressants, mood stabilizers, so on and so forth. And so there's tons of people that I personally know who were helped in the sense that their lives were more functional with the medications. Now, does more functional with consequences count as being helped? I would say so, yes. So I would say, in defense of psychiatry, I'm sure that millions of people have been helped by psychiatric medications. I have no doubt, 100% no doubt. And then Dr. Chris Palmer, who Nick is retweeting here, is focusing on using dietary and lifestyle interventions to help people with severe mental illness. And so you're telling me if Dr. Palmer is helping people stay on a ketogenic diet and exercising more and sleeping better and behavioral interventions to help them sleep better, and they're getting better, and that's part of his scope of practice as a psychiatrist, that's not medication strategies? Like, I think he's helping tons of people by helping people eat better, sleep better, and, live better, basically. So Nick, I have no doubt that different psychiatrists throughout the years have helped people live better through psychotherapy, medications, and lifestyle changes. I have almost literally no doubt. Now, follow-up question. How often are people harmed more than they are helped? That question has never been adequately addressed by the psychiatric or clinical psychology research. There are no really good follow-up studies that look at the preponderance of harm to the preponderance of help. It's just not there. And so we have some data that suggests that people are harmed rather frequently with mild or moderate adverse effects from SSRIs. We have some of that data. But that doesn't mean that in the sum total of that person's life, that they were mostly harmed or mostly helped. We don't know that for sure. So I think the question that will be addressed in the next couple of decades is how much harm is actually happening. So what I would say is it's really important to be clear that almost no intervention that a professional does with you, a mental health professional does with you, is all good, right? I think this is something that people really need to understand. And if you're out there and you're a family of a loved one in treatment or rehab, or if your loved one's going to therapy, or if you're going to couples therapy, or whatever you're doing, there is no treatment, zero treatment, absolutely zero treatments have only upside. Everything we do as professionals has some degree of harm. Everything we do. There is no therapeutic intervention that has zero harm to it. And I think that's important to state, which is why informed consent is so important. And I think I was talking about this earlier this week, because it's absolutely the case that some people delusionally believe that they're not causing harm. And that's just not true. I am fully aware of the fact that any therapeutic intervention I ever use can cause harm to people. It is not a question to me. And I think some professionals would like to believe that they're quote unquote mostly helping people. And I just don't think that's true. I think that if you're actually an ethical provider, you're crystal clear that there are going to be plenty of moments in the course of your professional relationship where harm is happening. And that doesn't mean you should give up. It just means you should figure out if that harm is necessary in the patient's words and in your ethical perspective, which requires a conversation about distress and suffering and impairment and checking in with people. It really does. Edmund says, can you define harm in detail? Okay, that's a good question. So when I teach this to my grad students, I try to be super, super practical. And I think it's really tough because there's a Mott and Bailey to this, which is you could define it loosely or rigidly. So what I'm going to try and do is avoid that trap. Excuse me. And what I really want to do is I want to be clear that I'm going to use a definition of harm that makes sense to me, how I see the world. If you out there view it differently, feel free to disagree. I would love to see your disagreement in the chat here, or come at me on Twitter and see if I'm not handling it correctly, because I just genuinely don't think that I don't think my definition is radical, but maybe you do. You know? So let me pull up, I did a tweet on this, so I'm just going to pull this up real quick because I think it's my actual thoughts. I don't think this is something I should make up on the spot. Okay. So this is something that I got into a back and forth with Franny Fanny about last, 2 days ago. So I'm going to retweet it so you can see it too, and you can fact check me and keep me accountable. Okay. Here we go. All right. So Franny Fanny, who I like, by the way, that was not the belt you're looking for. I'll try and go harder. So Franny Fanny said, in fact, being strategically harmful, not unintentionally harmful. So I gave some examples. If you're doing exposure therapy with people, especially ERP for OCD, then you know there's going to be intense distress at various points along the way over the course of therapy. They might feel overwhelmed. They might reach an 8 or a 9 out of 10 in terms of their distress. And we know for a fact that that is going to harm them, right? Another example is psychiatric medications, which I was just talking about. If you are in good faith being prescribed a medication where you are fully informed of all the different types of adverse effects. So if it's SSRIs, right, as the easy example, and the doctor does their due diligence and explains very clearly there are mood side effects, there are irritability side effects, there are drowsiness side effects, there are GI side effects, there are sexual side effects, there are risks of suicide or suicidal ideation. and all these things. And they spend like, let's say 15 solid minutes being very clear about all the potential consequences of taking the medication. And if they do their job correctly, and then you still choose to take it, and then you experience a numbness of your emotions, or a blood pressure issue, or a GI issue for a week, or whatever it is specifically, that's harm to you because those are harmful effects. But the medication's helping you in some way. That is you and your doctor knowingly engaging in harm for the sake of help, right? So I gave you a psychological example of intense distress at a like 7, 8, 9 out of 10. And I gave you a physical example of these adverse effects. So those two things I define as harm. Psychological distress, 7 or above out of 10. And then physical distress due to adverse effects from medications, right? That is intentional harm. And if you are aware that you're going to cause harm to someone, that to me is important. And I think very few people want to hold on to that and own that in the profession. Yeah, and this is exactly the metaphor I use. So thank you, dank memer, whoever you are. Exposure harm, like exposure therapy harm, could be equivalent to muscle soreness in the gym. Transient harm, but necessary for improvement. Exactly. And so I think the main difference between medical professionals and psychological professionals who are trying to be thoughtful and strategic and ethical are going to be aware of the fact that they are going to cause some degree of harm. And hopefully it's transient harm, like you said. It's temporary harm that goes away or becomes more tolerable over time. Now, you may not agree with my definition. Maybe you think saying being distressed at a 7 out of 10 is not harm, which I think is exactly what these people who disagreed with me, like Franny Fanny, would say. And I think it's absurd. I think it's absolutely absurd to try and like argue that you're not being harmful. Now, someone responded to me and said, you're being kind of like an edgelord. And I think, like, let me be 100% clear that if I'm going to do something silly and crazy, I'm going to state it very clearly. But if I'm going to talk about what I genuinely believe, then I'm not just trying to be some kind of edgelord or something. I believe very seriously, ethically, it's important to own what kind of harm I'm doing to people with people. And I think it's very clear that different types of therapies have greater or lesser risks of harm. And I think it's very clear that some people are aware of the harm they're causing and some people are not. And I think a lot of people in the profession are just cowards. I would be willing to bet that the vast majority of people that would like to rationalize away their harm to patients are just cowards. Well, Darren, and this is a good example. Darren just responded, so tell me if I'm name calling unfairly. Darren says, I'd say exposure therapy is more distress or discomfort than harm. So how are you defining the difference between distress and discomfort and harm? Explain it to me, right? Because like, I don't know that it's that black and white for most people. You know, to me, distress is harm. The question is harm all or nothing? I don't think so. I think it's shades of gray. Just like let's take the concept of poison real quick, right? Because I think this is one of those verifiable things in the land of chemistry and biology and toxicology. Poison, the difference for poison is just dose, right? The dose is what determines whether or not something is poison. And some substances are poisonous at very low doses, and others are very poisonous at only higher doses, higher concentrations. So to me, the same thing is true about harm. I think of harm and poison exactly the same. And that's true for everything that we do as professionals. And I would just be so shocked that it's not some degree of like wanting to look good or feel good about yourself, which I consider cowardice, that drives people's desires to not see themselves as harmful in the profession. And it's just like, you could be okay with harming people. You don't want to because you want to feel good or not be perceived that way. But the truth is, you are harming people. Every professional that I consider competent is harming people. Even the incompetent ones harm people. Club Exile says, Jeff, he says, I don't consider distress harm. There's a qualitative difference. Well, show me what the line in the sand is. For some people, harm could be something lasting, Dank Memer says. That might be true. I don't know. But I think the problem with the lasting qualification is I don't believe sincerely that harm has to last or not last. Do you guys not agree with my poison comparison? Because I think my poison comparison is pretty spot on in this particular context, but maybe it's not. Maybe you disagree. Because a substance, a chemical, is toxic or poisonous based upon the dose, not based upon whether or not it exists inherently as harmful. And I think the same thing is true of mental distress. Mental distress is harmful if you have no resources to manage it. And so for a lot of people, 7, 8, 9 out of 10 is harmful to them. They cannot manage it. They don't know what to do with it. And that's true in a lot of therapies. Ego death. This is another great example. If you're in therapy for whatever, right? And you're having a really ethical, close, effective therapeutic relationship, and that therapist is helping you, Club Exile says, I don't, for the reason that I don't see harm as simply concentrated distress. Well, if you can give me a definition that is like understandable to me and other people, I'd love to talk about it, because this is something that I think is crucial. And if I'm wrong about it, maybe there's something I can change. Show me the category distinction that you think exists, because if distress is not harm, then all sorts of things are not harmful that most people consider harmful, I think. But let me continue this thought process. Probably one of the most distressing things that happens in psychotherapy is a piece of yourself dies, metaphorically, right? Like you're in therapy. Let's say you're in couples therapy, right? You're in couples therapy and you're both just picking at each other's childhood scabs and you're arguing and bickering and name calling and yelling and all these things. And the couples therapist is like, hey, listen, I don't think this arguing, etc. is helpful. Can we try alternative skills, right? Because skills don't work. Next week you come back. By the way, why do we think we're doing this? It's because there's this piece of you, right? And if the couples therapist can help you see that there's this immature, unhealed, whatever piece of you, and you see yourself as one person in the relationship, but then as you start to work on this unhealed thing, that piece of you has to die. That's very psychologically painful, extremely painful. To the point that you might question yourself, your values, your relationship, and it might have serious consequences. You might end up not in that relationship anymore in some cases. And there's all sorts of like ego death that's not psychedelic related that happens in quality psychotherapy. And that can be very harmful. But that death is necessary for many people to heal in a way that's useful. Now, there are gradual versions of that, so it's not so intense and toxic per se. And then there are less gradual versions. It's kind of the difference between prolonged exposure therapy in some cases and more light exposure therapy models like EMDR. So to me, I can't imagine a world in which people are not being harmed by therapy. I just can't. Same thing with psychiatry. All those medications cause harm. Metabolic harm. They damage your liver. They damage your kidneys. Old school antipsychotics cause metabolic disease in many cases. It's so hard for many of these things to not be harmful to you. Dank Memer says, is harm necessary in therapy? I think so. I do. I genuinely believe in a not Dr. Hannibal Lecter way, as I was accused of by Franny Fanny. I genuinely believe that if you agree with my definition of harm, which is analogous to toxins and poisons, I genuinely believe that it's necessary. Now, how much that is necessary is not up to me. because everyone learns and grows at different rates. And there's very little that I can do as a professional in many cases for people to grow quicker, although I try. But sometimes people need to suffer more before they change. And that's not up to me. A definition of harm, I feel, may imply shouldn't happen. Well, what do you mean by that? What do you mean by shouldn't happen? Yes, Jeff, she called me Hannibal Lecter. And so I think it's really important to be clear that, like, I'm just going to joke around with her right now. So I genuinely believe, and I'm not upset at her, I think it's funny, but I genuinely believe that there is a pro-social way of thinking about this that is not about people experiencing some delight. You know, if you're a professional and you take delight in the fact that people are being harmed, that is very different than if you're like a neurosurgeon, for instance. Neurosurgeons who literally have to cut your skull open and poke around in your brain, probably to save your life, are literally causing all sorts of harm to you. They are cracking your skull open and cutting it open. They are literally slicing and dicing your brain with the intention of saving your life. So they are literally causing serious harm to the point that you could easily, not minimally, like very likely die, right? So they're harming you up to the point that you could easily die. And maybe those people are psychopaths. I don't know. I doubt it. Maybe they are. Who knows? But I think it's this question of, like, is there some way that we can be honest about the fact that the profession is not, quote unquote, about making people feel good? That sometimes people make choices in therapy, in counseling, in coaching, in psychiatry to intentionally harm themselves so that they can learn and grow better. Happens all the time. You know, because so much in therapy is extremely simple, but we're really good at overcomplicating it. And we complicate it to harm ourselves, for instance. Like assertiveness. Everyone and their brother can learn assertiveness skills. I feel sad when you talk to me that way. I feel happy when you hug me. I feel anxious when you communicate in a vague way to me. I feel unimportant whenever you don't listen to the thing I just said to you. The I feel statement is the simplest thing on the planet for everybody to learn and use. It takes 0 IQ points, basically, to use that effectively. However, most people don't do it. Most people continue to communicate in rather ineffective and counterproductive ways because they're playing games, because these psychological games serve some infantile attachment, whatever need, and they continue to harm themselves. And it's not my job to keep people from harming themselves. Dank Memer says, the harm you are describing, you are arguing is necessary. Is there another type of harm that should not happen? Absolutely. So quite legally and literally, there's all sorts of harm that therapists should never do. So therapists should never have sex with their patients. Therapists should never assault their patients. Therapists should never take financial advantage of their patients. Therapists should always engage in informed consent clearly and effectively in a way the patient can understand. Therapists should always stop therapy when it's no longer helping, if it can no longer be helped. Those are types of harm that are very crystal clear to me and my colleagues, I think. Darren says, perhaps the harm comes down to perception. Discomfort begins where your comfort zone ends. Facing it in small, safe doses with intent helps reduce the intensity of the feelings. Yeah, I agree with that. Progressive exposure, for sure. But I think the question is not progressive exposure. Like flooding is a big part of some of these therapies, right? But then this other question is unintentional flooding, right? Like some people experience intense emotions even if we're trying to do progressive exposure, right? And that's not on us. But it is helpful because their unintentional overwhelm is a signal about what's happening, which means we can work with it and it means something. And so that's what I'm saying is there is intentional harm that is helpful. And I just don't know how to explain it any other way other than the toxin and poison analogy, because I think it's the most accurate comparison. Intentional overwhelm is much better than unintentional overwhelm. Every type of therapy that's effective is in some way, shape, or form exposure therapy. It really is. Exposing you to thoughts you don't want to feel or feelings you don't want to feel, thoughts you don't want to think. I think they're the same thing, whatever. That is all part of effective therapy. Whether it's psychoanalysis or attachment therapy or EFT or behavioral couples therapy or ERP or whatever. It's all exposure. And so to me, it's really important that a clinical relationship exists if that intentional harm is going to happen, because then you have something safe and secure that you can, let's say, rely on and relax into, knowing that the bad thing's about to happen. It's like being on a roller coaster. You have, in theory, hopefully, a very secure seat with straps and seat belts and harnesses and all this stuff. So when you're whipping around the roller coaster, you're probably not going to fly off, though there are some experiences, unfortunately, where people do fly off and they do get decapitated and things like that. And I don't want that to happen. However, all engineering fails at some point, So that got really dark really quick. Maybe I am Hannibal Lecter. But what I'm saying very simply is, we can do our best to be a secure base for people, but harm is going to happen unintentionally, and hopefully, if we're doing our job correctly, intentionally in a controlled way. No differently than surgery. No differently than the expectable and obvious adverse effects of medications. No differently than therapy, where people have ego death or people lose relationships that they thought they needed and they have to grieve, right? A lot of people, when they start to grow and realize what their strengths and their needs are, they have to lose a bunch of relationships that no longer serve them. And that is grief, and that hurts. That is harm. That is psychological pain and distress. Now, most of the time, if you really are growing as a person and you do want to become something different that's better for you, in your opinion, that grief is worth it, because losing those people is going to make your life better, because now you're going to have better people in your life, people that suit your actual needs. I see this all the time in Rehabistan. For all of my life working in drug rehabs, people come into drug rehabs with all these intense, toxic, trauma-based, drug-based, codependent relationships. And they just cannot imagine their life without this other very sick person. And here's the deal. Almost every time, their life is way better without that other person who's getting high with them. So generally speaking, that's grief. It's intense psychological distress and pain. And their life sucks while they're going through grief because they've lost this person that they think they need. But then once they're sober, their life is better. They have healthier relationships, maybe a new romantic partner that's healthier for them. The grief is worth it. So I just cannot imagine thinking that we are harmless professionals. I think if the various types of professionals online wanted to look better, back to Dr. Perrin's question, what could psychotherapy do better to get its respect back in the public image? Maybe if we owned the fact that we do cause harm publicly and we weren't shy about it. We just told the truth, like I'm trying to do here. Darren said that my therapist once told me there is pain that can transform. Absolutely. That pain or harm is what's going to help a lot of people, in my opinion. Now, do I intentionally, sadistically want you to be in pain? No. I do not take positive delight in the suffering of other people. So, maybe I'm not Hannibal. I don't know. So for me, I just think it's very clear that harm is inevitable, and it's better if it's intentional rather than unintentional. But if unintentional harm happens, we can use that ethically, legally, to help the person. Rupture and repair, all these important things that happen in good therapy. She just responded, please tell me you got Hopkins as a guest. Sadly, no. Sadly, no. Sadly, no. So the thing about this is it shouldn't be complicated or controversial, but I think it is because people don't want to look bad. And I think that's really freaking silly. And the last post I want to talk about today, and by the way, thank you all for commenting and chatting. It really is helpful because I think we get somewhere different than when we started. So let me discuss this last post, which relates to the psychiatry and harm conversation. So I have no clue if I'm going to say his name correctly. And this is not meant with any disrespect. Is it Awais Aftab? I don't know if I'm saying it correctly, and I'm sorry if I'm not. His handle is at AWAISAFTAB. Okay? He's a psychiatrist who talks online a lot. And I respect him. I follow him. I talk about his ideas. And so he is deep in the middle of this fight related to psychiatry, Maha, fascism, whatever, all this nonsense, which I'm like, it's silly to me. But he said something I think that's important. So he was talking about this just a few hours ago today. He said, I know full well and again, the context of this is he's talking about the anti-psychiatry or critical psychiatry types. Here's what he said. I know full well the heterogeneity of ideas and backgrounds in the current alliance, which is like Maha, critical psychiatry, anti-psychiatry, etc. And I know that the focus is often on issues of iatrogenic harm, which are generally independent of conceptualizations of psychopathology. So here's what I said. That last sentence is completely incorrect. If your conceptualization of pathology emphasizes biological mechanisms, then it matters a great deal. Because one of the problems that psychiatrists and medical professionals really do need to grapple with, like if psychiatry wants to come out on top, if they want to overcome the insanity that is the Maha people and the anti-psychiatry people, they can do everything in their power to be super duper crystal clear about the verified and likely harms of psychiatric medications. I think if every psychiatrist who is not some hack idiot wanted to look good and come out above the fray and be reasonable, all they would have to do is say, this is a list of 10 obvious harms that come from psychiatric medications by class of medications, SSRIs, SNRIs, so on and so forth. And then category 2, these are the potential harms that are less likely but do happen, right? If credible people like Awais and other people online that I respect and like just said, listen, here's my comprehensive Substack piece that says these are the verifiable harms that happen frequently. And I fully admit that I prescribe these medications knowing that these harms are most likely. And also, these are the less likely harms, and I fully admit that I prescribe these medications knowing these harms are possible with plans in mind to manage them and prevent them from getting out of control. If doctors just said that, if psychiatrists just said that, all of this hell they're getting from trying to both sides things, and as much as I like Awais, I think he does a really good job of both sidesing things, and people hate him for that. But it's super clear, and it's not rocket science to say, these are the obvious verifiable harms that I am willing to put patients in the way of because I believe that the help outweighs the harm. And here's the list for SSRIs. Here's the list for SNRIs. Here's the list for mood stabilizers like lithium and Lamictal. Here's the list for first generation antipsychotics, etc. And then, essay number 2, here are some less than likely harms, but I know they could happen, and here's my plan to mitigate them. Because that's what's supposed to be happening in informed consent conversations anyways with psychiatrists. And if people just did that more publicly, then maybe society would have a lot more respect for them and they wouldn't listen to Maha as much. It's super not rocket science. But I think people are terrified of looking like they side with Maha, which is so stupid. Like, I care about sleep and diet and exercise, but I'm not a Maha person. And if you want to affiliate me with them, who cares? Like, I don't care what you think about me. I care that my ideas are correct and only that. I don't care if I'm for the right, the left, the center, the woke, the anti-woke. I don't give two shits. You know why? Because either the ideas work or they don't. And if it comes from someone with a red hat or a blue hat, if it comes from Sleepy Joe or Crazy Donald, I don't give a shit. Either it works or it doesn't. I just don't care. Dank Meme says, Atwab is moving the discipline in the right direction. He is conceding ground, but it takes time. Agree. Absolutely. Psychiatry is likely plagued by anti-litigation precautionary behavior for sure. They don't want to get sued. And fair enough. Sue me. Whatever. I don't know. I don't care. Life is short. Either I'm telling the truth, I'm right, I'm wrong. Who cares? Edmund says, thanks for the thorough discussion of harm. Absolutely. I think it's useful. Jeff, you said everything is now. What does that mean exactly? Everything what is now? I'm confused. So again, Ois, I hope I'm saying your name correctly. I think it's important to recognize that if you care about a biological model, then you're going to choose biological mechanisms that might harm people, including the ketogenic diet, for instance. So I think all this talk about not looking bad, not harming people is just, I just think it's so important to just be clear that none of us are perfect. We are all humans. We all make mistakes. Making mistakes is different than intentional harm. So unintentional harm is going to happen in any medical or psychological or clinical profession. It's going to happen. Intentional harm, for instance, exposure therapy, psych meds, so on and so forth, and the known consequences and adverse effects of these various interventions is something you should be discussing in informed consent conversations as your clinical relationship progresses at the beginning, middle, and end of the relationship. And the idea that any profession is free from harm is absurd. And there is a respectful, patient-centered, considerate, ethical way to be clear that I believe this potential harm or this likely harm is on the menu for us, and I believe that the help that is possible outweighs the harm that is likely. That is a very candid discussion that should be happening by every therapist, every psychiatrist, every counselor, spiritual counselor, pastoral counselor. Growing and healing and improving requires harm. It requires usually at minimum some kind of ego death, because this idea that people have about who they are is hard to let go of. And that goes for everybody I've ever worked with. Everyone has a story in their head that serves some psychological needs, some injuries, some defenses, whatever. And to grow means to let go of whatever you think is true about yourself and let it be different in some way that maybe you don't like in many cases. So I think it's very, very important to be clear that harm is necessary. And the question is how much, and can we be clear about it in the informed consent process? So that is my soapbox for today about harm. What an uplifting podcast this is today. Thank you all for being here and participating in the chat and things of that nature. It's been a pleasure having you all here. And if you heard something interesting, if you heard something useful, if you heard something challenging, if you heard a burp that you liked, if you heard whatever, please like, share, and subscribe. If you have loved ones who are in therapy or in treatment, this podcast is for them and for you, their family members. I want to make sure everyone comes out better informed with a critical, thoughtful understanding of what we're trying to do with mental health services. So that's why I created this, and that is why UnShrink Me happens every week, because new stuff comes out every week. So I'll see you all next Saturday at the same place and same time. Thanks, Darren, for the great chat. Thank you for being in the chat with me. And as always, if I have time, I like to end with a joke. So since we have some time, Phil, good to see you. Since we have some time, here's a joke. So I once had this patient. Very interesting case. Probably the first in my career that was like this. He had an interesting type of obsessive compulsive disorder that I'd never seen before. And so it was just kind of fascinating because it was new. So here's what happened. The individual had a counting obsession. Now, counting obsessions are not rare. In fact, in OCD, especially early childhood OCD, counting is one of the first kinds of obsessions that usually develops, to my knowledge, for OCD. So anyways, he had a very special kind of counting obsession. So what he would do is he would either have a watch, a wristwatch, or there'd be a clock in the room, an analog old school clock that had, 1 through 12 on it. And so his obsession was, he thought something catastrophically bad was going to happen, like his spouse was going to die, unless he counted to 12 every hour on the hour. So every hour on the hour, he had to count to 12. And he had to do it by looking at a watch or a clock on the wall. So that was his version of OCD. Very destructive because he could never get any sleep because he had to be up at all hours counting. So anyways, he came to me. We did some ERP, some exposure therapy. And it was rough because convincing him to do the exposures was hard. Convincing people to do exposures is hard. And we worked together for a long time. I'd say like 8 months, which is longer than usual for me with ERP. And by month 7, he had really gone through a lot of the exposures and was starting to see how intense the obsessions were and how irrational they are. And he's getting better at managing catastrophizing and all the cognitive distortions, all that stuff. We finally terminated in month 8. And in our very last session, he sits down with me and he goes, "You know what, Dr. Lockwood? I thought I was doomed. I thought I was never going to sleep. I thought I was never going to be okay again. This I have to get up and count thing, counting to 12, like it felt impossible. I thought I was never going to get better. And exposure therapy really helped me. And I was shocked that it helped me." And he said, "How confident were you that exposure therapy was going to help me with this counting to 12 clock thing?" I said, "Well, in my experience, ERP works like clockwork." All right, I'll see you all next week. Take good care of yourselves. Take good care of each other. Good food, good sex, good exercise, good sleep, and all those things. And I will see you very soon.